If it's okay, can we have Dr. Vaishali Gupta, because she also has to go to some other session.
Thank you. Thank you, Dr. Muscati, for the very kind invite and letting me speak. So I'm sharing my screen, but I don't see my slides. Yeah, perfect. So my topic, which has been given to me, is tuberculosis. And the big question that all of us ask while dealing with TB is TB or not, and when to start anti-TB drugs. So I'm very proud to be presenting this on behalf of Collaborative Ocular TB study that we initiated, and that has the endorsement from all the major international societies. So together towards tomorrow. To begin with, this collaborative ocular TB study was established to develop an agreement for initiating anti-TB treatment in patients with ocular TB. Because that's the problem when we tell a physician, when we are placed with a situation like this, they sometimes do not start. So how do we go about it? Now, I'm just going to show some case examples. For example, this is a 42-year-old man, sudden complaint, decreased vision, and you see there is acute uveitis and hypopyon, and it's a kind of a non-granulomatous uveitis. So the first and the foremost thing before you think of doing tests for TB or giving anti-TB drug is to understand whether the phenotype that you are seeing, is it suggestive of TB or not? For example, this particular phenotype is not suggestive of TB, so don't ever think of ocular TB in such a scenario. So this is a big no to treatment. However, if you have a situation like this, like acute granulomatous uveitis, mutton fat capes, nodules, synecdoche, and granuloma sitting on this, this is the kind of the scenario you would think of TB, you will test for TB, and if the tests come positive, you would tend to treat this patient. So of all the signs that we reported, if you see broad-based posterior synecdoche like triangular, which have the broad base, these are the ones which are very highly suggestive of tuberculosis. So these are some of the types which you will have to keep in mind before you start treatment. So when we did study on the consensus, we found that if you have anterior uveitis and you find all the three tests positive, and especially if the episodes are recurrent, that was the consensus to treat. The moral of the story is any acute anterior uveitis, you just have one test positive and it is the first episode and your phenotype is not even suggestive of tuberculosis, please do not treat, because we might be over-treating some of these patients. When we come to intermediate uveitis, now this is the phenotype which is not very likely to be tuberculosis. It's more likely to be sarcoid or any other autoimmune diseases. And TB treatment in intermediate uveitis does not work too well. So treat it only if all the three tests are positive. And that is what the consensus was, that intermediate uveitis, you would treat only if all the three tests were positive. Whereas if it's a pan-uveitis, you may tend to treat even if two tests are positive. Now coming to the more phenotypes which are very specific for tuberculosis. For example, this is a large granuloma sitting. And if you have this granuloma which has vascularity as indicated by arrows, this is a sign which is very, very typical for tuberculosis. A large single granuloma with blood vessels on the surface. If you want to compare it with the sarcoid, the top one is tuberculosis, large, single. The bottom one is sarcoid. The sarcoid granulomas are multiple, and they generally, very small. You may not see them clinically. When you do OCT, tuberculoma is large with involvement of outer retina. Sarcoid is buried deep, no outer retinal involvement, and no vessels on its surface. So the second phenotype, which is again very typical for tuberculosis, is serpiginous-like choroiditis, which we have the honor of, describing it for the first time. So if you see multifocality, if you have associated vitritis, anterior segment inflammation, and a phenotype like this, always think of tuberculosis. How would you differentiate whether it is TB serpiginous or autoimmune serpiginous? TB serpiginous tends to be unilateral, would have associated inflammation, begins in the posterior pole, and is multifocal, as shown here. Now, this is very typical of TB. Always think of initiating anti-TB treatment if the tests are positive. It's a busy slide, and I don't really want to, because I know I'm not talking to the uveitis group, but I would just like to emphasize that if you have serpiginous-like choroiditis, the experts agreed that even if one of the tests were positive, you would give anti-TB treatment. Same is true of granulomas. Even if one of the tests was positive, there was a very strong consensus to treat with anti-TB drugs. So to summarize, you are thinking about TB in a patient. If both the immunological tests are positive and your radiologic test, which may be CT or X-ray, is positive, you would treat such a patient. Even if just one immunological test, which is Monteus or IGRA, and you don't have, if both the immunologic tests are positive and you don't have radiology, you would still treat. And the phenotype is so typical that even if you have just one test positive, which happens to be Monteus in endemic population, 80% of the experts believed that it should be treated. When it comes to anterior uveitis, you treat only if there is recurrence, no need to treat first episode, and only if all the three tests are positive. If it is vasculitis like Eales disease, we no longer believe in Eales, but if it is active and it is occlusive and you have at least 2 tests positive, please treat with anti-TB drugs. But many times you would do vitrectomy for vitreous hemorrhage, which is so-called Eales disease. And after vitrectomy, you will find there are just healed scars. So if it is only inactive TB in the eye, please do not treat. Only the active disease should be treated. For any more information, we have these reports of the COTS consensus on when to start TB. Both the reports are published in ophthalmology, and we also now have an app which will be soon available on International Uveitis Study Group website, which will help the clinicians and comprehensive ophthalmologists to be able to start anti-TB therapy whenever they feel like, with no resistance from the physicians. And we also have it coming as the guidelines for extratubercular treatment, extrapulmonary treatment in national guidelines. Thank you very much for the opportunity. And thank you again, Dr. Muscati, for the kind.
Thank you, Dr. Vaishali. Can you tell us the full form of IGRA?
IGRA is immune-mediated assay, quantiferon gold, TB.
The quantiferon gold, no? It's just, yeah. Okay, fine. I thought so, yeah. Thank you. Thank you so much.